All right, over the next few minutes, we wanted to, in this section, give you a perspective of some of the newer drugs in lymphoma, because I think most of our discussion, the rest of the sessions are focused on specific debates, but there are a lot of new drugs and new agents out there. Some of them have been touched upon during the other sections of the meeting, particularly in the CLL section. Some will be touched upon a little bit later, so I'm not going to go into a lot of depth on a couple of these because I think we're going to come back to them, or you heard about them a little bit already. But what I do want to convey to you is a sense of what might happen in the future, and obviously we don't know, but there are lots of things that could unfold here. So over the next few minutes, I'll touch briefly on lenalidomide. You heard a good bit about that from Bruce Chesson. The BTK inhibitors, PI3 kinase inhibitors you heard about as well. We'll talk about anti-apoptotic drugs and the concept of nuclear export protein inhibitors. There's some interesting data with these agents in lymphoma. I'm not going to talk much about the novel anti-CD20s and the antibody-drug conjugates, mainly because most of those data are in CLL, at least with the CD20s, and you heard a good bit about those already. So first, you heard from Bruce on lenalidomide. I just want to give you a perspective of where that might be going and where it might not be going, depending on how the future holds and how studies hold. Bruce showed you a schema and some of the data from our study in relapsed follicular lymphoma. This was relapsed patients, not refractory patients, so they were a generally favorable patient population. Single-agent lenalidomide had a 54% response rate versus a 76% response rate and more CRs when you added it to rituximab. And the progression-free survival was improved in the doublet versus the singlet. You heard this already. So I think the question really is highlighted in this trial that's ongoing right now, the AUGMENT trial. Single-agent rituximab is used a great deal in recurrent follicular lymphoma. And the question, I think, will be, do we add new drugs to it? There have been attempts to do this with other agents. There was a study with bortezomib, for example, in relapsed follicular lymphoma, adding it to rituximab. There are a variety of antibodies that have been combined to rituximab, but thus far, the combinations with rituximab in follicular lymphoma and other lymphomas are relatively limited in demonstrating 2 versus 1 if the 1 in both arms is rituximab. So it'll be interesting to see how this study goes and whether or not we will be, in fact, using these doublets, this doublet in particular, versus single-agent rituximab, again, in recurrent follicular lymphoma. And you heard about this trial, the upfront study of lenalidomide rituximab, and Bruce mentioned this to you. So I think Dr. Fisher raised an interesting question, and Bruce was very confident about the study, and I think there's a lot of enthusiasm. I'm enthusiastic about this approach, but if you look at this in a very deductive and logical way, what does the future hold with this study? So 3 things can happen. One's better, the other's better, or they're the same, right? So the question is, how will the world play out amongst these different arms? And this is an ongoing study. If chemotherapy rituximab is better, I think then we'll continue to use it for most patients. The question will be how much better, how much more or less toxic it is, and really the long-term ramifications of, is it a progression-free survival benefit? Is there an overall survival benefit, which obviously changes things? If lenalidomide rituximab is better, then you basically have the same sort of story. Again, the tolerability of the approach and overall survival are really the key factors. And then if they're the same, then I think things don't change much, right? We treat follicular lymphoma in a lot of different ways, and we'll probably continue to do that. And these will be very individualized decisions. So I think what this point that I wanted to make here is that when there is a big overall survival difference in follicular lymphoma, the answer of what the future holds is easy. You do what makes people live longer. I think when there's either not a big but a small overall survival benefit or no difference in overall survival, then it comes down to how does the patient feel. And we typically make decisions and present data based on progression-free survival, but I think we really need to get a lot better about looking at quality of life. And you heard in the earlier debates about short-term versus long-term. We do a lousy job of kind of area under the curve of quality of life. Is it better to have more acute toxicity, less chronic toxicity, or is it better to have kind of low-grade, less toxicity, but for a longer time, which might be observed with some of the chronic therapy approaches. And so I think it's going to be very interesting. No matter what the study shows, I think this and other studies, it's going to be very interesting how this plays out. And it may be very different depending on what the results are. But I think at the end of the day, we have to keep our eye on the ball of, are the endpoints of the study correlating with people actually doing better? So I just want to mention large cell lymphoma. You're going to hear more about cell of origin and large cell lymphoma, so I'm not going to spend time on it, but just to point out that lenalidomide is active in large cell lymphoma. There's some data that reflected in this study suggesting in relapsed large cell that it's active more in the non-germinal center type. And that has led to analyses of using this agent with RCHOP, and I'm sure you'll hear more about this later. But I think one of the interesting things that the future may hold with lenalidomide is, are we using it with RCHOP? Is it a cell of origin directed treatment, et cetera? And I think we'll hear more about that later, so I won't spend time there now. I want to now move to the B-cell receptor antagonists or inhibitors, and you heard about this certainly in the CLL discussion. We have a number of different kinase inhibitors. I think for many patients they've changed the game, particularly in CLL, but they're also useful in lymphoma, and I think it's important for people in practice to know how these agents could be incorporated into our therapies for patients with mantle cell lymphoma, and potentially in the future large cell lymphoma, which I'm sure you'll hear about later too, as well as follicular lymphoma. So ibrutinib and idelalisib are the two on the right, respectively tackling PI3 kinase and, Bruton tyrosine kinase and PI3 kinase. So let's talk about those in various lymphomas. Okay. I guess I'm going in the other direction, sorry. So the various PI3 kinase inhibitors, again, Idelalisib approved for a subset of lymphoma patients. Copanlisib is in study, it's a delta and alpha inhibitor, and Duvelisib, a delta gamma inhibitor. So the point is that of PI3 kinase, there are various isoforms. You see that those with activity here in lymphoma are focused on the delta isoform, but there are other isoforms, alpha, gamma, that are, number one, operative perhaps in lymphoma, number two, are operative in certain subtypes of PI3 kinase inhibitors, and various of these agents, based on their selectivity, may also be applicable to various solid tumors. I'm sure you're familiar, many of you, with data in breast cancer and other malignancies where these drugs are being pursued. So first, Idelalisib. Idelalisib is now approved for treatment of patients with follicular lymphoma that is refractory to rituximab, refractory to alkylator agents. This is a study that was led by A.J. Gopal. It was updated at ASH. It's also been published. This took 125 patients with indolent lymphoma. Most of them had follicular lymphoma. They had all had prior rituximab, all had prior alkylating agents, all were refractory to those drugs, basically, and had a median of 4 prior therapies. So a fairly heavily pretreated patient population treated continuously with oral Idelalisib. The overall response rate of this study was 58%. These were primarily partial responses. There were some complete responses. You can see the various subsets along the bottom, but the majority, again, across the board, 50 to 60 to 80 in a small subset of Waldenstrom's patients. Predominantly, these were partial responses. So active, a variety of indolent lymphomas. And you can see the requisite waterfall plots where there were shrinkage in the vast majority of patients with follicular, SLL, marginal zone, and lymphoplasmacytic lymphoma. When you look at the durability of this across the board, about a year, median progression-free survival, seemed to be better than the last prior therapy, if you think that's meaningful, which for patients it should be, that you now have an agent that worked better than the last thing they got, and really quite similar across the different subsets. So about a 60% response rate, about a year PFS across a variety of indolent lymphomas. This seems to be a drug that's potentially useful across the spectrum of indolent lymphomas, in addition to what you heard before about CLL. So the adverse events are important to keep in mind for patients and physicians prescribing this drug. About half of patients have some element of colitis, GI symptoms. A smaller percent, about 20%, have more significant colitis and GI irritation, so you need to pay attention to GI toxicities with this agent. Also some fatigue, some fever, and a percentage of patients overall have also liver enzyme abnormalities, and that's something that you need to keep an eye on with this drug. There are some cytopenias as part of this treatment as well, but generally pretty manageable in the scheme of things. So Idelalisib is active as a single agent. It's been combined with rituximab, combined with bendamustine or BR. And when you look at them together, it seems to be pretty active in combination. Obviously, what it's being paired with is also active, so how much is one drug versus the other drug versus the combination remains to be seen. In this study, which has been presented at ASH, median progression-free survival of this kind of hodgepodge of combinations was about 3 years. So again, certainly reasonable. Hard to know what was the Idelalisib versus what it was being paired with, but certainly durable responses in relapsed patients. And so there are a number of different Idelalisib studies that are ongoing. You heard about the CLL studies. There's also a BR plus Idela in indolent lymphoma. There are rituximab Idelalisib studies going on, as well as ofatumumab in CLL. And so one would argue that this is an active single agent for recurrent follicular lymphoma, but also it might be useful in combination. And so the future may hold that these chemotherapy combinations with rituximab that we talked about earlier may be combined with a kinase inhibitor, and in follicular lymphoma in particular, and the data will really come down to, okay, does adding the second drug add efficacy? Does it add toxicity? What's the quality of life effect? What's the survival effect? And obviously, what's the cost effect as part of these sorts of combinations? So there are other PI3 kinase inhibitors that I mentioned earlier, and I just want to give you a flavor of them. They're worth keeping an eye on. They're not yet commercially available. One of those is Idelalisib. This is a PI3 kinase delta gamma, so it hits 2 isoforms. And this drug is given continuously in a study in indolent lymphoma, various doses, about 36 patients, mostly follicular lymphoma. Most of them had 3 or more prior therapies. The net of this is the toxicity profile seems to be in the same ballpark of what I reported to you in Idelalisib. Can't say that it's more or less, obviously not a comparative study, but it does can cause liver enzyme abnormalities, can cause GI toxicity. So in that regard, roughly similar to some degree. There were reductions in lymph nodes when you look at the patients getting 25 BID, which is felt to be an optimal dose. So high activity here and high overall response rates in the patients, 60 to 70% overall response rate based on what dose they were getting. So this seems to be an interesting and active drug in lymphomas. The question will be, how do we use it, combine it, and how does it differ from Idelalisib, at least from the clinical perspective and the clinical spectrum of using it. The other drug I'll just mention is Copanlisib. This is a delta alpha PI3 kinase inhibitor. This is given intravenously, and in various studies it's been looked at or being looked at alone and in combination. In follicular lymphoma in particular, it has a 40% response rate in a limited number of patients, also has some activity in mantle cell and other lymphoma subtypes. So we'll see how this agent moves forward as well. So it may be that all these drugs with respect to lymphoma patients are quite similar. They may differ in toxicity, or they might differ in efficacy or one subtype versus another. So we'll see how this plays out. But certainly, by the fact that we have several PI3 kinase inhibitors, all of which seem to have meaningful activity in various lymphomas, suggests that this is an important pathway that we'll be hearing more about and learning more about, and presumably targeting more in the future. So now to BTK inhibitors. I'll be brief on this aspect of things. You heard about this in CLL, and I think you'll hear more in the large cell talk. But ibrutinib is approved in relapsed and refractory mantle cell lymphoma, where it has about a 70% response rate, durability and progression-free survival in the range of a year to a year and a half. So this is an active and important drug, I think, in recurrent mantle cell lymphoma. And whether or not you had prior bortezomib, this seems to have meaningful activity. So again, something that can be useful for many of our patients. But Peter Martin and our group have shown that if you have mantle cell lymphoma, you get ibrutinib and you progress on ibrutinib, you don't do so well. So the interpretation of this could be one of several things. One is that something changes in the tumor cells after they get ibrutinib. They're more resistant, they're more unfavorable, Or the other interpretation, or another interpretation, is that just these were bad patients, they'd had a lot of prior therapy, this was more or less the last effective treatment, and they didn't have other good options. So I think this is an interesting observation. What we do with this, I think, will be very important. I think the idea of combining other drugs with ibrutinib is really where the future in mantle cell, I think, holds, certainly in the relapse setting, and where will we use ibrutinib as part of upfront therapy, certainly in mantle cell lymphoma, remains to be seen. In large cell lymphoma, there's evidence you'll, I'm sure, hear more about, that it may be useful based on cell of origin, also in the non-germinal center subtype, and we have studies focusing on that group, looking at RCHOP, and again, you'll hear more about that later. What about follicular lymphoma? Usually things work better in follicular lymphoma than anywhere else, it seems like, in lymphoma, but it seems like in ibrutinib's case, Nancy Bartlett presented some data from ASH, 40 patients, recurrent follicular lymphoma, median three prior therapies, 30% overall response rate, 10-month progression-free survival. So you can interpret this as meaningful activity. We should take it forward and start combining it with lots of things. Or you could say, well, there are lots of things that have a 30% response rate in follicular lymphoma. Maybe ibrutinib is a very good drug for various lymphomas, but follicular, it's one of many, so to speak. So I think you can look at that in different ways depending on your perspective. These are interesting data. I think it doesn't definitively answer the question, and there are a number of studies further looking at the role of ibrutinib there. But I think it's not so clear to me, at least, that this is a major advance in follicular, or at least as much of an advance as it is certainly in CLL and mantle cell, but time will tell. So where are we going with ibrutinib? Follicular lymphoma combinations, large cell I mentioned, and I think a lot more in mantle cell lymphoma, because that remains an area of unmet need, and yet is an area where ibrutinib seems to have meaningful activity, and if we can combine it properly and understand resistance properly, we may be able to do a lot more there. And we have a number of studies looking at clinical trials of different combinations with ibrutinib in recurrent mantle cell right now at Cornell. So in the last minute or two of my talk, I just want to give you a sense of a couple of other drugs you should keep an eye out on. You've heard about them elsewhere in this meeting, and I want to talk about where they fit into the lymphoma spectrum. So BCL2 inhibition, and in particular ABT-199 or Venetoclax. So this is a BCL2 inhibitor that has been looked at in a variety of different studies. You heard about it in CLL. It's also active in mantle cell and in other lymphomas, and there are a number of different dosing schedules that you can see summarized here on this slide. One of the issues with this drug has been tumor lysis in some of the early studies, and so the dosing regimens have often involved a stepped-up dosing schedule where the patient starts at a low dose and then ramps up as time goes by, and the risk of tumor lysis is reduced. So this is an experience presented last year, 62 patients, a variety of lymphomas, mantle cell, about a third of the patients, large cell lymphoma, about a third, and various indolent lymphomas being also about a third, median of 3 prior regimens. So the data here, you see the requisite waterfall plot. About half of patients had 50% or more reduction, so basically more or less 50% objective response rate. You see a number of the orange bars going down in mantle cell where the responses were a bit higher, and then a variety of other studies. This is the non-CLL population, which you heard about separately, but there are some activity here in Waldenstrom's, some in follicular, and in other lymphoma subtypes as well. When you break this out, the response rate's about 68% in mantle cell, 28% in large cell lymphoma, about a third of patients in follicular lymphoma, and a hodgepodge of a few other patients in other subtypes. So certainly this is a drug that's of interest to pursue further, given the importance of BCL2 in various lymphomas. And what we're going to see next is combinations. We're already starting to see some of that. This is a bendamustine rituximab combination. There are ongoing RCHOP combinations, and I think we'll see other drugs or standard regimens being combined with this to see if adding the second agent can improve efficacy in various lymphoma settings. So I think this is what the future holds with this drug, and the questions will be, you know, what's the tolerability of these combinations, and what are the trade-offs, efficacy versus toxicity, where there'll be differences in dose intensity of chemotherapy when you add a drug that has some cytopenias as part of its effects. So time will go with these, but I think we'll see more of these combinations as time goes by. And I just think I mentioned those things. Finally, I want to mention briefly two different categories. This is just one slide on nivolumab. I was talking with somebody earlier about checkpoint inhibition in lymphoma. We hear a lot about it in Hodgkin's. I'm not presenting you the Hodgkin's data today. I think people have seen that in various sources. But what about other lymphomas and the variety of immune checkpoint inhibitors that are in clinical trials in heme malignancies and other tumors? We see that nivolumab is one example, and I think there are limited data in many of the other immune checkpoint inhibitors, some activity in a small number of patients of follicular lymphoma, large cell lymphoma, T-cell lymphoma. And so this is an area that seems to be most dramatic in Hodgkin lymphoma, and I think in the other lymphoma subtypes where these agents will fit, I think remains to be seen. Certainly if we can identify biomarkers where these drugs may be more effective, it will be of particular interest. And then finally, I just want to mention a newer class of drugs. That is the selective inhibitors of nuclear export, or SINE drugs. So the idea is that we have trafficking of various growth factors in and out of the nucleus, and these are trafficked through pores, various pores. One of those pores is depicted here on the slide, and there is a nuclear export protein called XPO1. High levels of XPO1 expression are associated with unfavorable outcome in a variety of lymphomas and other hematologic malignancies. So XPO1 is bad, presumably because various growth factors are staying in the nucleus more, and tumor suppressors are not circulating appropriately, and the net effect of that is an unfavorable outcome. And so if you can inhibit XPO1 and inhibit this nuclear export, you might have anti-lymphoma effects. So selinexor is one of those drugs. This is a drug that is an oral agent. It does have some toxicity, particularly fatigue, nausea, diarrhea, some cytopenias. So it is a drug that does have some kind of quality of life side effects as part of it. But interestingly, in small dose-finding studies in large cell lymphoma and other lymphomas, it has activity. And I think what's most noteworthy, and this is emerging, it's a moving target, you see a little bit of data in various abstracts, that somewhere around 30 to 40% of a limited number of large cell lymphoma patients, transformed lymphoma patients, Burkitt patients, double hit patients in the relapse setting seem to be responding to this drug. So it's early. Obviously, durability matters, and we need to see larger numbers of patients. But I think for relapsed and refractory aggressive lymphomas in particular, this is a drug that we've seen, and we have trials with this open right now. We've seen a few very interesting responses, more data to come. So this is my last slide. I think we have lots of new agents in lymphoma that are coming along. Obviously, combining these effectively, identifying the patient subsets are going to be key, as is using the appropriate endpoints. Response is obviously important, PFS is important, but at the end of the day, doing a better job of having regimens that improve overall survival and being able to wait till we see that. And most importantly, quality of life and cost, and increasingly those are tied together for some patients, will be important as we figure out where these drugs will move forward. So thank you very much for your attention. I'm happy to take a question or two. Otherwise, we'll move to our break.